So we'll wait for one more minute before we start. And I'm hoping that Dr. Rukmini joins by then. She said that she'll be joining in another couple of minutes.
Hello.
Hello. Good morning, sir.
Good morning.
Good morning. I've just joined. Sorry, I'm actually traveling. So I will just keep in. But if my connection goes bad, then I will have to take out. But it's very good. I'm very impressed with the good work that you guys are doing and the high educational value of your webinars. So keep it up. And the young brigade is the most crucial segment of any body, including the Indian Academy of Neurology. So please carry on. I'm all ears, and as long as it's possible, right? Okay.
Right. Thank you. Thank you so much, sir. Thank you.
Right.
Good morning, Dr. Ayush. I'm audible.
You're audible.
Okay.
We'll just start in another couple of minutes. Just one glitch. We'll be through that very soon. So I guess we can start the case. Dr. Rukmini will be with us in another minute. So Asmita, can we go live?
Yes, sir, you can go. Sir, room is open. You can start.
Very good morning to one and all present here. Welcome to another webinar of the Indian Academy of Neurology Young Neurologist Forum. We can call this our monsoon session because there is incessant rainfall everywhere. And without further ado, I would like to hand over the mic for the first case, which will be presented by Dr. Farzana and will be moderated by Dr. Vikram Hola and Dr. Rukmini. So over to you, Dr. Farzana.
Thank you, sir. Am I audible, sir?
Yeah.
Yes, ma'am, you're audible. Is my screen visible? Not yet, ma'am. You can share. Is it visible now?
Yes.
Thank you. Respected senior faculty and all the colleagues, I'll be presenting a case. We titled the case as Steady Gaze and Unsteady Gait. I'm Dr. Farzana MK, Senior Resident of Neurology in Nimans, Bangalore. Going to the case. Our patient is a 57-year-old gentleman, right-handed, studied up to pre-degree, is from Andhra Pradesh, presented with complaints of gait instability with recurrent falls for 1 year, drooping of the eyelid and eye movement abnormality for 1 year, change in speech and swallowing difficulty for 6 months, and emotional lability for 3 months. The gait instability started insidiously, which was gradually progressive in the form of difficulty in walking with unsteadiness, and he started walking with the feet wide apart. He had to take more steps while turning, and it was associated with recurrent falls, predominantly backwards. And recently he used to have daily falls. And there is no difficulty in gait initiation. There is no freezing or fascination or no swaying while walking. There was no worsening on eye closure, or there was mild difficulty in raising from the floor. Otherwise, there was no weakness. Drooping of the eyelid was also noticed 1 year ago. It was insidious onset, bilateral, asymmetrical, that is right more than left side, which was partial. And there was no fatigability or any diurnal variation, no double vision or squint noted by others, no frequent blinking or difficulty in eye opening. The eye movement abnormality was noticed by the patient's wife. There was progressive difficulty in moving the eyeball, especially while walking. While walking, he was not able to look downwards, and later he had to turn his head to look the objects on the sides also. And he had more difficulty while climbing down to look and he used to trip and fall. And no squint were noticed by the patient wife, or there was no complaints of double vision. The change in speech was also present for the last 6 months. There was reduced clarity of the speech, and there is increase in speed and the loudness. The words used to jumble as he keeps on speaking with the loss of modulation of the sound. There was no difficulty in initiation, no any scanning of syllables or explosive nature. He was able to understand what is spoken to him, and there was no word finding difficulty or naming difficulty. The swallowing difficulty was noted more for liquids, and he had occasional coughing. There was no nasal regurgitation, nasal twang of voice or choking episodes. And for the last 3 months, he has inappropriate laughter and crying episodes. No history of any cognitive impairment, behavioral symptoms, visual hallucinations, any psychotic symptoms or fluctuating sensorium, seizures or myoclonus. No slowness, stiffness, tremors or hyposmia or sleep disturbances. No feature suggestive of alien hand phenomenon, levitation or dystonia. No limb weakness, wasting fasciculations. No sensory or bowel bladder symptoms, no headache, vomiting or autonomic symptoms, and there was no loss of weight, loss of appetite or other systemic symptoms or any drug intake. The past history was significant for history of diabetes for the last 10 years, for which he was on medication, and he was a chronic smoker, and the family history was not significant, and he has not started on any medication when he presented to us. So to summarize, we have a 57-year-old man. He's diabetic for the past 10 years with no significant family history, presenting with progressive neurological illness of 1 year duration characterized by gait instability and recurrent falls, drooping of the eyelids with ophthalmoplegia, and dysarthria, dysphagia, and emotional lability.
You can stop here, Farzana.
Okay,
Anything, should we discuss here, or any additional history examination, history findings anyone wants to know?
I think we can start the discussion, and then anybody wants to know anything, they can ask.
Sure. You can go to the next slide, Farzana.
Okay. So the functional deficit that our patient has is the initial symptom was gait imbalance and recurrent falls. Though he had a significant history of falls, history-wise, they are clearly telling that there was no swaying while walking or no significant worsening on eye closure or any other sensory symptoms. So I would like to localize the gait imbalance and recurrent falls, most probably to the postural instability due to loss of postural reflexes. And the second possibility I'll consider will be the cerebellar ataxia.
You did say that the patient had a broad-based gait, right? So
yes, sir.
So
that's why I kept the cerebellar ataxia also as a possibility, sir.
Okay.
But
so what are the features? Okay, you want to go through the entire thing, or we'll just say what are the other features of postural instability that you're finding here or you're not finding here?
A patient predominantly has gait imbalance and also recurrent falls. That is predominantly while turning, he has difficulty. He has to take more steps and he tends to fall backwards. And also he has some difficulty from raising from the floor. During that time also, he has a tendency to fall backwards.
So what about when he's sitting down?
Ma'am,
When he's sitting down.
stepping down, he has
Sitting down.
sitting down. He is stable, ma'am.
Now, when he tries to sit down, like, I mean, on the bed without back support, does he have any tendency to fall backwards in that position also?
Mild sway is there, sir, to backwards.
And what about when he sort of tries to get up, I mean, from the chair? Does he tends to fall back on the chair, or these are all the features that?
Yes, sir. From the low, from raising from a lower chair, low seat, he has a difficulty, sir. He tends to fall backwards. He has to make 2-3 attempts. From the bed, he is able to raise normally, sir.
Okay.
So I think that's what the tendency to fall backwards. I mean, especially whenever there is change in posture, the patient is not able to maintain the upright posture, and sort of reflexes are not intact. That is why maybe, although it is very difficult in the history, I suppose, to say whether it is ataxia or postural instability. But the point being noted is, I mean, although he has a wide base gait, the wide base is usually a reflex for any sort of instability or any difficulty in walking. Except for in case of Parkinson's disease, despite significant gait abnormality, still they tend to have a narrow base, or a spastic gait where the narrow base is there despite patient is having a significant walking difficulty. But every other possibility, wherever there is walking difficulty, the patient tends to maintain the posture by maintaining a wider base. So wider base also suggests ataxia. It may not always suggest that it is cerebellar in origin, and it can be because of various other reasons. Like, for instance, if the patient is cautious, slippery surfaces, there also the gait becomes wide even in the normal individuals also. I think the postural instability in this may be, I mean, slightly, the examination finding may differ or may say otherwise, but the tendency to fall backwards predominantly and turning and getting up from the chair, getting up from the ground, the patient is having predominant backward falls, is sort of a feature suggestive of postural reflex abnormality rather than cerebellar ataxia. So that is the reason I think the person has kept probably postural instability more compared to ataxia, but historically both remain strong possibilities, and it is difficult. Maybe examination will help us in identifying which may be the more likely possibility. Now, you're saying anything?
Yeah, so the thing is that the other thing that you can always ask about is the injuries. If you think that the patient is, like, suppose you have postural instability, they tend to fall completely. So they would probably hit their head quite frequently, more often than not. So the other question is that do they buckle on their knees? Does he sit down when he's falling? Is he just falling like a log? That all would help. Because even if you have, say, backward falls is correct, that you have postural instabilities, you tend to fall backwards, but they are soft signs. As Dr. Vikram has already said, that if you have broad-based gait, it can be anything. It can be a cerebellar ataxia, it can be a sensory ataxia, it could be anything, because people tend to be a little cautious and walk little, with a broader base, except for those in Parkinson's disease or in spasticity, where you would expect that they would have a narrower base. So did he have any injuries? Like, did he sit down? So that sometimes even with the cerebellar ataxia, they may tend to fall backwards, but they would rather sit down, and they would actually, they do have these writing reflexes to some extent. They have some protective reflexes. So complete loss would definitely be useful, but a lot of times you don't get the history so well. So we can see it on the examination. I think you can keep both the possibilities right now. Though there are no
injuries,
yes, sir. Few occasions he has injury, and most of the falls are like en bloc falls rather than sitting and falling.
Right. So more likely to be postural instability than cerebellar ataxia. So we'll keep the cerebellar ataxia quite, just that there may be a component of it, but more like, definitely there seems to be postural instability. So you think you can localize it?
Postural instability is localized to the pontomesencephalic junction. We have the pedunculopontine nucleus, which is the most important locomotor structures which help in the maintaining posture, and along with that, locomotor centers, we should have our all the senses like vision, sensory, and also the and vestibular, and also the motor, cerebellar, and extrapyramidal system should be intact.
Correct. Okay.
And
That's
also
fine. Go
the
ahead.
frontal structure also may involve, I mean, in a patient with a frontal apraxia or frontal instability, you say, no? If there is subcortical frontal impairment, they also will have loss of writing reflex and they tend to fall backwards. So that also gets involved in the postural instability. So that is what usually sometimes may happen in NPH or the frontal predominant structure involvement. So that is why frontal ataxia, that is a loss of writing reflexes may be there. The patient may not have insight also and may not have a writing reflex to prevent the falls. Yeah. Go ahead, next one.
Going to the eye movement abnormality, patient had developed progressive difficulty in eye movement, which was more prominent initially in the down gaze, and later it became complete according to the history. And for this, as there is no significant diurnal variation or fluctuation in the symptoms, and it was asymmetric, and there was no double vision at any point of time, and there was no squint noticed by the attenders. So I would like to keep supranuclear as the first possibility, though we have to examine and clarify.
What are the, I mean, for or against for muzzle or NMJ? I mean, you told just to, I mean, make it.
There is no patient has developed gradually progressive difficulty in eye movement. There was no in NMJ. We classically see patient will have fatigability and diurnal variation or fluctuation in the symptoms, and it will be usually asymmetric, and there will be double vision. In case of muscle also, there will be, if there is a involvement of the asymmetric involvement of the muscle can cause double vision, and there can be squint which can be manifested. And also in nerve, there can be associated double vision, and there can be squint, and all these features are not there, and it was gradually progressive, and the patient has initially difficulty in looking downwards, followed by in other direction also.
Rukmina, you are muted. Ma'am, you are muted.
Yeah, just one second. I'm sorry. I get what you're saying for nerve and neuromuscular junction. Muscle need not. So muscle normally, when you think of a muscle disease, what muscle diseases are you thinking of?
Mitochondrial myopathies or ocular.
Symmetrical.
Yes, ma'am. They will be symmetrical and
diplopia.
Yes, ma'am.
So correct. So even with supranuclear gaze palsy also, you can get diplopia. It's rare, but you can. But as you said, diplopia is more a feature of neuropathy or a neuromuscular junction abnormality. Muscle diseases can also have slowly progressive restriction of their eyeball movements. The fact that you have an associated drooping. So okay, so you are so your drooping is not clear where the localization for the droop is, but if you have a drooping of the eyelids, I would think that there probably is a bit of a muscle weakness rather than supranuclear gaze palsy. Right. But again, these are all very soft signs. So if you want to differentiate between, say, a muscle weakness versus a supranuclear gaze palsy on the history, it's difficult actually.
It will be difficult.
Yeah. Except the fact that if you're very sure that it started with down gaze, see, sometimes it's difficult for the patients to identify where the movements stop. Right. So if it is starting in the down gaze and then it is going up, then it's more likely that you are probably having a supranuclear gaze palsy. If you think of mitochondrial disease, you would expect that the horizontal gaze becomes abnormal before, then you get the vertical. Yeah. But again, these are all very soft signs, so examination would be better.
What were the histories that the patient gave for down gaze predominant impairment?
While walking, as the wife reported, while climbing downstairs, he had more difficulty than climbing upstairs to fall while climbing downstairs. And she noticed that while walking, he was not looking down.
Yeah, not looking down can be because of two reasons. What are the two reasons? One is that there is a gap.
Can be due to the axial neck rigidity also, patient not be able to flex and look down, or it can be due to extraocular movement.
So did he try to look down? He was not turning his face, the head down.
He was able to, ma'am. Initial stages, he was able to look down, like flexing the neck.
Yeah, so this is the only because of the symptom complex. So basically, just because on the supranuclear gaze palsy, you can't really decide. But because when the patient, so there's a little bit of loss of insight into what he has.
Yes.
Here, this seems to be that there's an added component that he seems to look up even when he's climbing down, in spite of the fact that he's falling. So that means that there is definitely a cortical involvement somewhere where he's not really bothered about it. If you have a muscle NMJ neuropathy, there will be a lot of compensation done by the patient, which is not happening here. Just this is an associated component. It's not the symptom by itself, right?
Next.
And the drooping of the eyelid was asymmetrical, right more than left, with no diurnal variation or any fatigability from the history, and there was no associated double vision. And I would like to keep the possibility of partial ptosis versus blepharospasm in this case. And patient didn't have a... Sir?
No, that's a partial ptosis only, maybe, I mean, because of the asymmetry blepharospasm and maybe a bit less likely. Partial ptosis, yeah. I mean, again, the localization may be supranuclear, nuclear, or the muscle and NMJ. And because of the ophthalmoplegia associated, maybe we can pinpoint that. And asymmetry, as ma'am told, would go in more favor of either a nerve or NMJ. Or sometimes muscle also, but usually muscle, slowly progressive, predominantly mitochondrial or muscular dystrophies, OPMDs, will have a more of symmetrical, and also the supranuclear also tend to have a symmetrical. So, yes, ma'am. You can go to the next.
Go ahead. So what is your gaze? What would be your vertical gaze center?
Vertical gaze center is in the midbrain, ma'am. We have burst neurons in the RIMLF, and for the neural integrator is the interstitial nucleus of Kaha.
Both you think upward and downward has got the same level, or you think there might be a difference?
I'm not sure.
Do they crossover? Do they have bilateral representation? There is a difference up and
down. Yes, ma'am. Down gaze has unilateral representation, and up gaze has bilateral.
And also it loops around the.
It loops around the posterior commissure to the opposite side from one side.
Go ahead.
Go ahead. Next.
Next is dysarthria. The patient has a change in speech in the form that he started speaking fast with less clarity, and the words were jumbled together, and he was fluent according to the history. So I would like to keep a hyperkinetic versus ataxic dysarthria rather than hypokinetic or spastic or classic dysarthria.
Yeah, this is a little difficult. So when you call a hyperkinetic speech, what are you actually referring to?
The speed and the speed of the speech has increased, ma'am. And also there is loss of modulation of the sound, and the words are being jumbled together. Some variability is there in the.
Logically, that should make sense. But unfortunately, when you have speech disorders, no, hyperkinetic and hypokinetic actually refers to the movement disorder of the patient itself.
Yes.
So you have fascination speech in, say, a patient with Parkinson's disease, it is still a hypokinetic speech because the hypokinetic movement disorder is there with the speech. Unfortunately, I mean, that is how this is illogical, but it is like that. So whenever you say hyperkinetic speech, it means that the patient has got a hyperkinetic movement disorder rather than the speech. So it becomes a little confusing. That's so you can, okay. So you can.
Can we call it
this is
dyskinetic speech versus
you can call it
ataxia?
you can call it fascination of speech. So there's a speech fascination which is happening. He's tending to speak faster. That's what you said. He's speaking fast, and there's a jumping of speech. Correct.
Yes. And next symptom is dysphagia. A patient has only minimal symptoms in the form that occasionally he used to cough while having liquid food as compared to solids. And there is no history of any nasal regurgitation, nasal intonation, or other difficulty in having solid foods. So, as there is no nasal intonation, nasal regurgitation, the element that is bulbar weakness is less likely. And along with the other features of dysarthria and all these, I would like to keep the pseudobulbar, that is corticobulbar fibers.
Usually the bulbar or muscle or NMJ will be more of element, may have nasal intonation and regurgitation. So it is not necessary that it always happen, but if it is less common, then it is more likely that the tone is still maintained, and these features are less common in UMN type of bulbar weakness. And also you have emotional ability also. So sometimes you may have to associate it with the other symptoms and say what is the most likely possibility. So you can explain all this dysarthria, dysphagia, emotional ability by a pseudobulbar or a pyramidal involvement. One single description, if you have to give, that is most likely possibility is UMN localization. As I told, corticobulbar fibers may be the most likely possibility. Yeah. Anything else, ma'am? For lack of time, I think we have to move. It's just half an hour, no? For one. Okay.
You can take up to 40.
Okay. Thanks. Anything else, ma'am? Deficit localization, any other localization you want to point out?
So when you ask for the family history, what are the family histories that you're asking for?
We have to ask for movement disorder in the form of any Parkinsonism or other movement disorders, any psychiatric illness or any cognitive impairment, and also history of any MND.
So the question that has been asked is that when can we localize all of them together, because there is dysphagia, dysarthria, the gaze palsy, everything put together, can we localize? You can, but it's sometimes better to localize it separately because you may have combinations more than others. And where to localize the ptosis in this patient, we will look at the examination and then take a call on where exactly to localize the ptosis.
At this point, just adding that there are questions in the chat box also. Dr. Sandeep has asked, can we localize dysarthria, dysphagia, and emotional ability together, and ophthalmoparesis and gaze paresis together? And Dr. Shekhar has asked that where to localize ptosis in this patient?
That's what I've been answering. So we will go ahead.
Yeah.
These are the two questions that have come. Correct. Go ahead.
Thank you. So considering the symptom complex with postural instability and supranuclear, probably gaze palsy in this patient along with the pseudobulbar features, would like to keep the differential diagnosis first as a neurodegenerative PSP. Points in favor are the age of onset in the 6th decade and progressive symptoms, early falls, postural instability, and oculomotor abnormalities. And though as the symptoms are of short duration, that is only 1 year, I would like to roll out other PSP mimics like paraneoplastic etiology, especially related to anti-MAR2. The points against are no constitutional symptoms or other sleep disorders, which is classical in MAR2 related paraneoplastic PSP, and autoimmune etiology like Eglon 5 related. In that also, if this patient does not have a sleep disturbance or any other autonomic features. And the vascular PSP being considering the age and vascular risk factors like smoking and diabetes, and also bipyramidal symptoms like pseudobulbar, I would like to keep vascular PSP, but vascular PSP usually the onset can be acute and they will be asymmetric, and the lower limb predominant symptoms will be there along with the cognitive and bladder symptoms which are absent in this case. And I would like to keep structural lesions like slow growing gliomas in the midbrain and tectal region. Also in this case, though there is no features of raised ICT and the duration is also more than 1. And other rare causes of infectious PSP like Whipple's disease due to rapidity of progression and the PSP phenotype, I would like to keep it no systemic symptoms, no diarrhea, weight loss, or oculomasticative myarrhythmia or other arthritis in this patient. Apart from the PSP mimics, I would like to consider sporadic SCAR2 because of the gait ataxia and eye movement abnormality, though the age of onset is little later and there is no family history. And as there is the ptosis of thermoplegia with some difficulty in raising from the floor, and also patient has diabetes and ataxia, I would like to keep mitochondrial, that is Polg related. And there is no, though there is no family history. And other rare possibilities of Niemann-Pick, as there is supranuclear gaze palsy and ataxia. The points against are the age of onset is quite late, no cognitive or psychiatric symptoms, and no features suggestive of gelastic cataplexy. And the rest possibility, NMJ, I would like to keep because of the ptosis of thermoplegia and doubtful difficulty in raising from the floor, though there is no fatigability or diurnal variation. Can I go ahead with the examination?
There are some questions. I mean, hypo versus hyperkinetic speech, usually predominantly hypokinetic is more of a low volume. I mean, so the volume most of the time, and apart from that, hypokinetic speech, as ma'am told, there'll be loss of modulation. And also, I mean, sometimes it may be a bit fast. So as ma'am told, I mean, sometimes the speed may be more in, despite having a hypokinetic speech. So the characterization is not a watertight. So hyperkinetic is usually a bit varying volume. It may look like a ataxic speech, but sudden stoppage or sudden cessation of the speech because of the dystonia in the laryngeal or the bulbar muscles, that can lead on to the hyperkinetic speech. Mainly the volume, I mean, most of the time may help you in sort of differentiating, because hypokinetic speech predominantly will be of low volume, apart from the other features that are there. So, but again, I mean, it is not necessary that you should, I mean, decide on the history itself. Otherwise, there will not be any role of examination. Based on history, is it possible to keep it in one of the groups is what we have to attempt. If it is not possible, then you can say the same thing, that based on the history, whatever evidence we have, it is difficult to say for now what type of speech it is. Most likely it may be this, but I cannot rule out the other possibilities definitely. In this case, very unlikely that it is element type of speech because of the various features. The other mixed cerebellar, spastic, hyperkinetic, hypokinetic may also be the possibility, but history-wise, element seems very unlikely. Rest of the things are possible. And any sleep disturbance, I think already Fazana mentioned that the sleep disturbance were not there. Sandoz syndrome, again, it is a terminology used for Polg. So sensory ataxic neuropathy, deafness, ophthalmoparesis. The patient doesn't have predominant sensory symptoms or deafness, but these are all, it may not have full phenotypic penetrance. So examination may give us some more clues, but it is still the mitochondrial Polg is kept for that reason itself. But although the pseudobulbar effect, predominantly postural instability, all those makes it a bit less likely, but examination we may be a bit wiser. So Dr. Divya has told to add to the list of DDs, late onset Gaucher's 2, the horizontal more than vertical gaze abnormality. Yeah, I mean, these are all the sort of DDs. It is a big list of PSP mimics. So we thought maybe these may be a bit, but all of this, the Gaucher's disease also, as rightly pointed out, more of horizontal. But just on the history, we cannot completely rule out that it is vertical, not horizontal. We have to be open in the history and just make to think what may be the likely possibilities, but it doesn't mean that the other possibilities are ruled out. So history as open as possible. And based on the examination, we'll try to rule out the possibilities that we considered or rule in the possibilities that we did not consider, but we got a strong evidence for a particular illness. So I think, ma'am, anything additional to be added?
And the question for ptosis, we will look at the examination and get it back. So I think people are asking for where the localization is. That should be fine. Again, hyperkinetic is always confusing. The reason why I'm saying it's confusing is that if you have a PSP patient and the patient's speech is loud, you still put it as hypokinetic speech. Unfortunately, that's the dictum. If you have a PD, even if the speech is fast, you put it as hypokinetic speech. That is illogical, but it actually puts the whole movement disorder together. So if you have a choreic speech, definitely you know that it's a hyperkinetic speech. In this patient, because we're considering PSP, we will think of a hypokinetic speech. That's all. Otherwise, as you said, it could look like a dyskinetic speech. PSP patients can have a loud booming voice because they have that spastic component also. So they have that barking or a growling speech, which is typical of PSP. Anyway, let's go ahead with the examination.
Yeah, go ahead.
It's good.
So patient's vitals were stable. No postural BP fall was there. And I'll just show the video before you can observe that the patient has a hypomimia and also reduced blink rate. Other general physical examination was normal. And higher Mendel function showed MMSE of 26. He lost point mainly in attention calculation and also 1 point in orientation. And Ferrandel assessment battery, he scored 11 out of 18. He has difficulty mainly in the set shifting and also conflicting instructions. ACE3 showed 75 out of 100. Predominantly, he had deficit in the attention and fluency. And language was normal. There was no apraxia. I'll show the speech now.
ನನಗೆ ತೊಂದರೆ ಆಗಿದೆ ಕುಂತ್ಕೊಳ್ಳಲು ಹೇಳಲು ತೊಂದರೆ ಆಗಿರುವುದರಿಂದ ನಾನು ಬಿಟ್ಟಿರುತ್ತೇನೆ ಕೆಲಸವನ್ನು ಬಿಟ್ಟಿರುತ್ತೇನೆ.
So the patient has the volume of the speech is normal to high with a loss of modulation of sound, and also there is accelerated production of the syllables. At times there is jumbled up voice and he is fluent.
You think there's a repetition?
Yes, ma'am. Some perseveration was also there.
ನನಗೆ ತೊಂದರೆ ಆಗಿದೆ. ನಾನು ಎಲೆಕ್ಟ್ರಿಕ್ ಕೆಲಸ 1 ವರ್ಷದಿಂದ ಬಿಟ್ಟಿದ್ದೇನೆ ಆದರೆ ನನಗೆ ತೊಂದರೆ ಆಗಿದೆ ಕುಂತ್ಕೊಳ್ಳಲು ಹೇಳಲು ತೊಂದರೆ ಆಗಿರುವುದರಿಂದ ನಾನು ಬಿಟ್ಟಿರುತ್ತೇನೆ ಕೆಲಸವನ್ನು ಬಿಟ್ಟಿರುತ್ತೇನೆ.
No gaps at all. He's just going through speech completely like that. Right.
So this
ನನಗೆ ತೊಂದರೆ ಆಗಿದೆ. ನಾನು
the components which are there.
Patient has the volume of the speech is normal to high with loss of modulation, and also there is accelerated production of the syllables, and he is fluent. So this kind of speech can be called as tachyphenia with some oral festination and also some perseveration. He was repeating few words.
Correct.
Again, the confusion will be whether to level it as you rightly pointed out, hyperkinetic. So
this is because I have been having this confusion since the time I was a resident. So I have been told, and I've looked around, and people have. That's why that is always a problem, because if you only look at the speech, it looks like a hyperkinetic speech. If you put it together with the movement disorder, it becomes a hypokinetic speech. So maybe we should just leave those, the terminology there separately and just say that he's got oral fascination or tachyphenia. That is easier to speak, and he's got a loud volume. Correct. Go ahead.
And visual acuity and fundus was normal. There was partial ptosis. You can see in this bilaterally more on the right side than left, and it was non-fatigable. And
so when we call it ptosis,
if the cornea is covered more than 1/3, or if it touches the pupillary margin.
Right. So if it touches the pupillary margin, it becomes like a moderate ptosis. So even if this is probably very mild, so what do you think is the reason for the ptosis here?
And one more thing in examination I want to show, ma'am, the patient is able to voluntarily elevate the lid on eye movements. So,
correct.
Is it?
So what do you think is this? Yeah?
Some like aponeurotic kind of shifting. I'm not sure.
You're right about it. I would say that it's probably a mechanical component which is there because of the skin which has become more lax on top. Go ahead.
Yes.
That Look
So
like a
I'll show the
neural.
eye movement.
Right.
Eye movement. So these are the saccadic movement. We are checking. Patient is asked to look to the left side. You can see that there is increased latency and reduced velocity and amplitude of the saccades in both horizontal and vertical direction. More evident in the vertical, especially down gaze. Now we are looking for the pursuits.
Sorry to interrupt. We've got 5 more minutes for this case. We're already, time is up, but 5 more minutes.
The patient has significant limitation of the range of movement and also the velocity in all directions. And on VOR, we are able to overcome the ophthalmoplegia to some extent.
Making it supranuclear. So that's the only way of differentiating between the infranuclear and the supranuclear. Go ahead.
Then OKN was impaired in all directions. Jaw jerk was brisk and palatal movements were normal. Gag was brisk and the tongue was normal. And there was pseudobulbar effect during the examination and Upler sign was present. On motor examination, there was grade 2 axial and grade 1 appendicular rigidity and power was normal. Deep tendon reflexes were 2+ and angle was absent. Plantar was bilaterally flexor and primitive reflexes in the form of palmar-mental and Meyersson was present. Sensory was normal except for the impaired joint position and vibration in the lower limbs. No cortical sensory loss and Romberg was positive and bedside autonomic function test was negative. Extrapyramidal, there is hypomimia, reduced blink rate, axial and appendicular rigidity, and there was a doubtful bradykinesia on the left side. And it's more of a fast hypokinesia than bradykinesia. The speed is, the velocity is good, but the amplitude has come down. No tremor, dystonia or myoclonus. And the cerebellar examination showed mild left hand incoordination and the knee heel string test was normal. Going to the gait, patient was able to get up without any support. He was upright posture with normal arm swing and there was a wide base and some turn hesitation. He has to take more steps while turning. And tandem was slightly impaired. And on pull test, patient was having tendency to fall. And one additional finding I have to demonstrate is the patient's handwriting. Patient was writing very fast with micrographia. And towards the end, it was becoming very illegible. This was the sample handwriting. And this phenomenology is called tachymicrographia, which can be seen in PSP patients. And other systemic examination was normal and there was no testicular enlargement. To summarize, 57-year-old man with diabetic for 10 years with no significant family history, presenting with progressive neurological illness of 1 year duration, with frontal predominant cognitive impairment, vertical predominant supranuclear gaze palsy, hyperkinetic fascinating speech and pseudobulbar effect, axial predominant rigidity, fast hypokinesia and postural instability, lower limb large fiber sensory impairment with absent angle jerk, and so currently patient is dependent for the activities of daily living.
Very nice. Nice presentation, actually. So, a couple of questions. What is hypokinesia, bradykinesia? Just can you differentiate between hypokinesia and bradykinesia?
Hypokinesia is the reduction in the amplitude of the movement, and bradykinesia is the speed, velocity of the movement.
Correct. So this fast versus slow micrography is another question that people have asked. So do you think that
It was fast micrography. What, ma'am?
Yeah, will that make a difference or give you an additional point in your
Yes, ma'am.
diagnosis?
Yes, ma'am. In Parkinson's disease, the patient will have micrographia, which will be slow, and if the patient has a fast micrographia, that will favor in terms of PSP diagnosis.
Again, this is a soft sign. So even with PD also, you can have fast micrography, but as you said, a slow micrography is more common with PD.
Yes.
Right. So does the patient have round the house sign on gaze movement?
Ma'am? No, ma'am. Actually, patients' movements were so restricted so that
There's nothing. The possibility was not there. Correct.
yes, ma'am.
Sure.
So
at the end of
yes, ma'am. So considering the age of onset more than 40 years with progressive symptoms, and the patient is fulfilling the criteria for a PSP, vertical supranuclear gaze palsy is there, repeated unprovoked falls, and also frontal cognitive and behavioral presentation.
Do you think you would like to still think about the other differentials that you had after the exam, after the history, or now you're confirmed that it is going to be PSP?
I would like to consider other etiologies, mainly because the duration of illness is only 1 year. So I would like to rule out other, especially this paraneoplastic and also autoimmune etiology. And as there is risk factors for vascular risk factors, I would like to rule out vascular etiology also.
Since we're running short of time, can we just have the diagnosis and the MRI of this patient, and we can quickly move on to the next case, please?
Yeah, I'm just
Yes,
going. So investigation-wise, everything is normal except for sensory-motor axonal neuropathy and HbA1c. The patient had neuropathy. Maybe it is unrelated to PSP, and maybe it is just a long-standing diabetes. This is the MRI. Can you tell about this, Fazana?
Yes, sir. So the patient has significant midbrain atrophy that you can see as compared to the pontine volume, which is maintained. The midbrain is atrophied, and also on the axial section, and in the axial section you can see there is loss of the convexity of the tegmentum of the midbrain. And these are the name signs explained in PSP. The first one is hummingbird sign. And next is a profile sign, that is when you draw a line on the superior aspect of the midbrain in the sagittal images, there will be a convexity of the superior margin of the midbrain. And also there is significant atrophy of the superior colliculus. And then the second image, you can see that there is a decrease in the pontine, the ratio of midbrain to pons, and also there is the diameter is reduced on the pons, which is meeting the criteria. And the third image shows the classical Mickey Mouse or morning glory sign.
So thank you for the lovely presentation, Dr. Pradana, and the discussion, Professor Rukmini and Dr. Vikram. Now, without further ado, let's move on to the next case that will be presented by Dr. Raghav and discussed by Dr. P.K. Maurya and Dr. A.K. Singh. Over to you, Dr. Raghav, for the case presentation.
Am I audible?
Yes.
Good morning, everyone.
Please start.
Actually, the system is handbook, so just give me a minute.
No problem. I think there are two devices that are logged in somewhere around you because there's an echo.
I start, Dr. Rao.
So is my presentation visible?
the echo come from your device?
Good morning, everyone. I'm presenting a webinar on acute and chronic neuropathy. It is a less often considered etiology when we are considering patients with neuropathy. So I have two cases to present. The first one is a 31-year-old lady. She presented to us with weakness of lower limbs, which was acute in onset, preceded by a sense of heaviness in both lower limbs while traveling in the car from New Delhi to Mount Uttar Pradesh. 12 hours later, when she tried getting out, she could not and needed support and was also unable to grip her footwear, and she needed support to walk. Her symptoms progressed over the next 2 to 3 days such that she required support in getting up from sitting down position. And over the next 4 to 5 days, she developed upper limb weakness, which was distal more than proximal. Her symptoms were progressive such that over the next 4 to 5 days, her proximal and lower limb and upper limb weakness, it started worsening, and she was unable to get up from the bed without support. So there were no complaints of any associated sensory complaints like tingling, paresthesias, dysesthesias, or any painful complaints, allodynia or hyperalgesia. There was no bowel and bladder involvement. There were no kidney nerve involvement. There was no neck pain, no sensory level, no pain abdomen, seizures, or altered sensory. The patient was admitted elsewhere and she was treated symptomatically. Due to worsening of symptoms, she presented at her institute at day 18 of illness. Past history was not significant, and she had received 2 doses of COVID vaccination, the last dose which was received in August 2021. Her family history was significant. She stayed with her in-laws. Her husband works abroad. There was similar history amongst family members with the onset of illness around the same time, with the total duration of symptoms being around 3 weeks. Her mother-in-law had headache, multiple episodes of vomiting, and loose stools to begin with, and this was followed by lower limb weakness and upper limb weakness after 2 weeks of the gastrointestinal illness. When the index case got admitted, her mother-in-law was quadriplegic. Her brother-in-law developed generalized weakness with buckling of knees with difficulty in walking. However, the duration was short compared to her mother-in-law, and he was ambulatory. Her father-in-law, he had headache and vomiting, followed by gastric distension, took local treatment at home, and had mild improvement in his symptoms. However, with the coming time, he developed whitish skin and oral lesions, followed by difficulty in walking. He developed persistent vomiting, and because of which he was admitted elsewhere, and he succumbed to his illness within 2 days of admission, and it was treated as cholera according to the patient, but there were no details available. Her brother also had generalized weakness and myalgias, which was followed by oral ulceration, vomiting, and loose stools. He had also gotten admitted, and he also succumbed to his illness within 3 days of admission. On the examination, the general examination was normal, except there were presence of hyperkeratotic skin lesions present over
Dr.
both.
Raghav, before
Yes.
we go on to examination, would you like to discuss the possibilities after your history? What were the things that you considered? Because let's go by history, followed by examination, followed by the final diagnosis.
Yes, sir. So this is a patient who presented with an acute onset of sensory motor quadriparesis, which was lower motor neuron in nature, as there was no evidence on history of upper neuron involvement. And also she had no bowel and bladder complaints. There were no cranial nerve complaints, and only mild heaviness was present in the form of sensory loss, but there was no other sensory complaints. But the thing which stands out here is that the patient had family history, and the people who were living with her family, they also had a similar history. So in this scenario, we considered the possibility of a toxic etiology.
No, see, again, what was the localization that you had? So for element weakness, sensory motor, what are the possibilities of localization that were considered before we go
First
on?
localize. Summary localization.
So we can localize the element of weakness to First the anterior functions, then
But
to-
Raghav, you said that there was sensory loss. How will sensory loss be explained by
no,
the?
sir. Actually, there was just heaviness, sir.
Okay. All right.
Most likely possibility was neuropathy, sir. Nerve involvement. Then second was neuromuscular junction involvement. And muscle involvement can also be a possibility. So there is symmetrical distal involvement. There is sensory complaints in the form of heaviness, and the patient.
Okay.
There was
So in the background that the family had diarrhea, what all etiologies are you considering before we go on to the examination part?
So first is botulism is one possibility which I am considering, since they can have bad food or tainted food. It was one possibility. Some OP poisoning was also suspected as a possibility, and since it can also present as weakness and quadriparesis later on. And so third was toxic etiologies was also considered, heavy metal toxicity.
Can it be just a normal GB syndrome where the patient had diarrhea and after the diarrhea, the patient developed this progressive?
And GB syndrome was also considered, so it can be also there, sir.
Okay, please
But
continue.
Because of the clustering of illness, mostly GB syndrome occurs sporadically. That's why we have considered it in the differential diagnosis, but we have kept it at a lower down.
Right. Okay, please continue.
What is the cluster presentation of GB syndrome? Is it proximal involvement or distal?
It is proximal more, sir, rather than distal. It was distal more initially, and then it progressed proximally.
What is the usual time of progression of GB syndrome?
So the weakness progresses from 2 to 14 days, and by the 14th day, it can reach its nadir, but sometimes it can continue to progress up to a period of 4 weeks, after which the progression ceases to exist.
So basically, you're saying that there was a length-dependent involvement, right? Which is predominantly motor, and there was some associated complaints of diarrhea and GI symptoms in the family.
Yes.
Okay. So please go on to the examination.
So on examination,
I would like to know what could be the cause for death in this family member.
Actually, toxic, most likely the cause of death was hypovolemia and resulting from excessive vomiting, which was present in both her father-in-law as well as in her brother, sir, which could have resulted in shock, and thereby they might have succumbed to their illness, sir. And they were being treated on the lines of an infectious etiology outside, sir, but the exact details I do not have.
So if it is poisoning, then which poisoning most commonly occurs?
There can be arsenic poisoning is a very close differential to cholera. It can result in nausea, excessive vomiting, resulting in hypovolemia, and can result in an untimely death, sir.
And how you differentiate on the basis of history botulism?
In botulism, a patient will initially have a period of nausea and vomiting, but the most important symptom is the presence of gastroparesis, which is lacking, which was present only for a mild period of time, but more significant history was of that of nausea and vomiting. And in botulism, there will be also craniobulbar involvement, which is more predominant, along with respiratory complaints, which were not present in our series of in this family.
Is there any dermatological manifestations in these two cases in those two causes?
In arsenic, so there are presence of dermatological abnormalities, which can be in the form of hyperkeratotic, hyperpigmented patches, which can be present on the palms, over the abdomen, over the skin extremities. There can be nail changes as well, sir. In the general examination was normal, except for the presence of hyperkeratotic skin lesions present over the palms and there was hypotonia and wrist drop present. In neurological examination, her higher mental functions were normal. There was no cranial nerve involvement, no facial weakness. However, there was hypotonia present in all 4 limbs. At the time of examination, power was more affected distally in the upper limbs compared to the lower limbs. In lower limbs, although there was proximal weakness, but initially she had distal weakness. And at examination, distal was more than proximal. All the deep tendon reflexes were absent. Plantars were bilaterally flexor. And on sensory examination, we got loss of joint position sense and vibration sense up to the ASIS in the lower limbs and at the wrist joint in the upper limbs. So, all to summarize, this is a 31-year-old female who presented with an acute onset element sensory motor quadriparesis without autonomy, without cranial nerve involvement, with similar illness in other family members around the same time. So this was a sensory motor polyneuropathy. Since it was length dependent and had more distal involvement first, we considered it as an axonal cause of polyneuropathy. So the differentials which we considered, owing to the presence of similar complaints in family members and the clustering of cases, first differential we considered was heavy metal toxicity, and amongst them thallium, lead, and arsenic, OP poisoning in its intermediate syndrome and in the induced delayed polyneuropathy, botulism as a cause of neuromuscular junction involvement, tic paralysis, and Guillain-Barré syndrome. We have kept it there, but we have kept it at the last. So the points which favor the presence of heavy metal toxicity are the presence of skin lesions and clustering of cases within the same family having almost similar nature of complaints. However, there was no occupational exposure and there is no history of any herbal medication or supplementation intake. In
skin lesion, acute arsenic poisoning and what arsenic poisoning?
In acute arsenic poisoning, the skin lesions are mostly the presence of hyperpigmentation and hyperkeratosis. But in chronic poisoning, we can appreciate the presence of transverse lines over the nails, such as Mees lines, and there can be raindrop or pigmented excoriating lesions which can be present and distributed over the soles of the feet and at other, and there is diffuse hair loss also present chronically. And points which favored the presence of OP poisoning were again the clustering of symptoms and their delayed onset. However, apart from just gastrointestinal symptoms, there were no other muscarinic symptoms such as bronchoria, salivation, and excessive lacrimation. There were no neuropsychiatric manifestations, no ataxia, and no ocular symptoms. For botulism, again, the symptoms which favored the presence were the multiple family members which were involved, but there was no descending symptoms, no ocular bulbar involvement, and no sensory complaints. For tic paralysis, acute onset, flaccid areflexic paralysis, and minimal sensory symptoms were favoring, but the patient lacked ataxia, craniobulbar symptoms, and there was no scar present on examination. And for GBS, an acute onset preceding GI illness, ascending sort of paralysis with minimal sensory symptoms were favoring it, but the presence of skin lesions, however, and the history of similar complaints in family members and the disease not being sporadic, this was against its diagnosis. So,
Dr. Raghav,
yes, sir.
just sorry to interrupt you. So you have written that the point against that there no sensory involvement. Actually, botulism is a neuromuscular junction disorder. So usually we think that there should not be any sensory involvement. So it points in the favor, but in some cases the paresthesia has been reported and mostly attributed to the compression. Patient is prolonged bed bound and due to the compression of the nerve, these have been reported.
Thank you. On investigating the patient, her complete hemogram, biochemistry, and serum electrolytes were normal. The lumbar puncture done was suggestive of albuminocytological dissociation with mildly elevated proteins. Nerve conduction study was suggestive of an axonal sensory motor polyneuropathy affecting the lower limbs and upper limbs with absent F waves. We also did RNS and we observed no decremental response at stimulating at 3 Hz. So this was the nerve conduction study which was conducted. It reveals firstly, there is absence of any sensory nerve action potentials in both upper limbs and lower limbs. And similarly, in the lower limbs, the motor action potentials are also absent. There is mildly raised latencies involving the left median nerve and stimulated at the APV. She had also got an MRI of the cervical spine done where she was admitted outside. It was normal. Inflammatory markers, vitamin levels and viral markers were negative. In lieu of the skin lesions and because of the presence of similar history amongst family members, we had suspected toxic as one of the causes of the neuropathy. So we sent an urinary spot arsenic level, and also we estimated the 24-hour arsenic level, which was highly and significantly elevated. So this patient was diagnosed as a case of acute onset symmetrical sensory motor axonal polyneuropathy secondary to acute arsenic toxicity. And this meets the diagnostic laboratory criteria of arsenic poisoning according to CDC guidelines, which states an elevated urinary arsenic level of greater than 50 micrograms per liter for a spot, and also greater than 50 micrograms total for a 24-hour urinary sample, which can be determined by commercial laboratory tests. So,
arsenic from lead and helium.
So in arsenic poisoning, there is predominantly painful involvement. There is alopecia, which is present, and it is axonal, but it can also be demyelinating in nature. Hence, it can mimic GBS. In cases of thallium poisoning, there is excruciating pain, which is a hallmark, along with alopecia, and it is mostly an axonal pathology, but no evidence of demyelination. In lead, most common manifestation tends to be encephalopathy, but when it presents as a neuropathy, it is also of the axonal type, and patients can have significant wrist drops, which can be seen along with other hematological and manifestations such as the presence of anemia and evidence of bone marrow suppression. Also, there can be presence of significant basic constipation. Yes, wrist drop is.
Yeah,
So,
move on to the next case.
Yes, sir.
to which you give more importance, the blood levels or urine levels, and why?
Urine levels are more important because, and actually more important that those is the presence of its in hair, because it can persist for even a longer time.
So it is rapidly removed from the blood, but
It is, yes.
binds to the keratin. So
It
those
is-
cases in which keratin is present, there it persists for a long time, even up to 6 months, we can make a diagnosis.
Dr. Raghav, there's one question from the audience that what was the source of exposure of arsenic in this patient? Since you said that the patient was not taking any alternative medications, the family was also affected. So what was the source?
So this could not be determined at the time of history because according to her, what were the sources, because actually this case is an ongoing medical legal case, and maybe there's a possibility of suspected poisoning in this.
Right. Okay, right. Thank you.
Probably some Kuttu Kahata was like that in this patient history. They had brought from the village and kept after kept in the refrigerator. Otherwise, some toilet from the neighborhood and water possible source from the likely possibility. some court cases pending, so we are not going in detail.
So you're muted, sir, so we can't hear you very clearly, actually.
Okay. So, patient, there are two possibilities of exposure in this case. One is a patient has taken kuttu ka atta during Navratra Vrat. So one possibility is that they have, after mixing, kept in the refrigerator, and took after 2 days. But that was brought from the village area. Second possibility is some neighborhood, there was some quarrel 20-30 days back, and suspected water poisoning from the top roof water tank. But no other members of the other flats were involved. So some medical legal case is going on. We don't know what will be the source. Routinely in chronic arsenic poisoning, there were different districts which are involved in and categorized at grade 1 to grade 5. Just Lucknow is in category 4. Those Gorakhpur and Azamgarh in that area, it is category 5. So she was a resident of Mau district. That is category 4. So we don't know exactly what is the source in this case.
All right, thank you.
We want to go into the next case. So we manage.
Sir, please unmute yourself.
So we managed this patient with antioxidants and physiotherapy, and she received D-penicillamine, and she had showed improvement in her symptoms later on. The second case is of a patient. He's a 43-year-old gentleman who presented with an acute diarrheal illness of 10 days duration, followed by weakness of all 4 limbs, which was acute in onset, involved the distal lower limbs, then the upper limbs, also distally, and these symptoms developed within 7 days after the acute GI illness. And this was associated with tingling, paresthesias in hands and feet with progressive numbness. However, there was no loss of consciousness, cranial nerve involvement, any band-like sensation, bowel and bladder involvement, abdominal pain, or joint pain, or any rash. His general examination was normal. The neurological examination was normal except for hypotonia. And on power examination, he had mild weakness in the toe grip and hand grip, but the reflexes, they were depressed in the upper limbs but absent in the lower limbs. And all modalities of sensations were reduced from the wrist and below the ankle. So this was a case of an acute onset sensory motor element quadriparesis without bowel and bladder, autonomic or cranial nerve involvement. Since it was distal predominant, we considered the possibility of a sensory motor polyneuropathy, and we considered the various differentials such as GBS, vasculitis, acute intermittent porphyria, and toxic neuropathy. And the patient was investigated. The initial hemogram, biochemistry, and serum electrolytes were normal. His first CSF examination was normal. NCS, which was done at the day 8 of ictus, which revealed the presence of bilateral median and ulnar sensory neuropathy, along with the presence of mild left ulnar axonal motor neuropathy. So in view of, and there were absent F waves involving the common peroneal nerves and also in the left median nerve. So in view of gastrointestinal illness, progression of symptoms post that illness, presence of areflexia and weakness, we considered a provisional diagnosis of GBS in this patient. This patient was given IVIG. However, during the course of the treatment, due to his financial constraints, the patient opted for discharge, and he was given discharge on request with supportive treatment. However, 10 days post-discharge, the patient represented to us, he was readmitted, and during this period, he experienced increased weakness in the lower limbs, inability to bear weight, dragging of feet, and he started to require support to walk. And the distal hand weakness, it started to worsen, and this was associated with severe sharp shooting pain in the feet and legs. Examination at this time, general examination was still normal. Neurological examination, there was hyporeflexia. However, the power this time had significantly reduced. It was almost zero at the ankle, and there was involvement of knee flexion more than knee extension. In the upper limbs, the patient had more distal weakness. However, the proximal weakness was not present. The reflexes this time were absent in all four limbs, and all modalities of sensations were now absent up to the level of the knee and involving bilateral hands. So the patient was re-evaluated. A repeat LPCF was done. This time it was suggestive of mild increase in the levels of proteins, other inflammatory markers, nutritional panels, thyroid function test. It was normal. The NCS done this time revealed the presence of demyelination with secondary axonal changes, and F-wave was absent. As we can observe in this NCS table that the latencies are markedly prolonged in the left and right median in the upper limbs, with similar prolongation involving the right upper limb, and there is also associated decrease in the amplitude of the left and right median nerves, and the sensory
Would you like to see that there's a conduction block? If you look at bilateral ulnar nerves.
Yes, sir.
Bilateral ulnar.
Yes, so there is.
Slowing up the conduction velocity and conduction block is there.
Yes, sir.
Please continue.
Proceed. Yes. So there was absence of F waves. So we considered this as the worsening of the initial GBS symptoms, and this time we gave this patient a full course of IVIG, 2 grams per body weight distributed over 5 days. However, we advised the patient to continue to remain admitted because we were unsure about the nature of the illness and for its progression. So there was no improvement observed, and the patient, he continued to worsen. So this time we again re-evaluated the history, and other differentials were considered, such as acute onset CIDP, vasculitic neuropathy, acute intermittent porphyria, infectious polyradiculopathies, and inflammatory causes such as sarcoidosis. So to rule these conditions out, firstly, we went for a 24-hour urine porphobilinogen levels, which were negative. We underwent ANCA, ANA, CANCA, PANCA, and ENA profiles, which came out to be negative. To rule out infectious polyradiculopathies, we did the test for CMV and Lyme's. It was negative. HIV ELISA was negative. ACE levels were normal. And we also sent an ganglioside antibody panel, which was negative. So in view of the progression of the illness for greater than 4 weeks and treatment-related fluctuations with the evidence of demyelination and conduction block and NCS, a possibility of acute onset CIDP was considered, as I told previously, and he was also given a 5-day course of injection methylprednisolone, and following which he also reported no improvement. However, during the hospital stay, the patient was made to stay continuously because he was receiving physiotherapy care under the department of PMR. So he opted to stay in the hospital. So around at day 40 of ictus, the patient developed.
Sorry, Dr. Raghav, just asking, after pulse steroids, since you considered a diagnosis of acute CIDP, was the patient continued on oral steroids or some steroid agent?
He was continued on oral steroids, sir. So we were waiting to look for any improvement, but there was no improvement, sir.
So was any other immunosuppressant considered? Like if the patient of CIDP does not improve to pulse steroids, we consider giving cyclophosphamide, rituximab, something of that sort?
So not at this present moment of time, sir. We were planning to start it, but in the subsequent days, we were still considering it, but it was not yet started, sir.
All right.
So around at the day 40 of ictus, the patient developed skin and nail changes, which were not present at the time of admission. There was excessive hair fall, which was observed. On reviewing the history, he confirmed the intake of herbal medications for at least 3 years. And the medications which he took were Cap Shilajit, Cap Ashwagandha, and Cap Nutrigold. And hence a possibility of toxic neuropathy then was considered. So this is the image in which we can see a transverse line involving the nacullae of the nails. This is a transverse whitish line known as Mees lines, which can be seen in cases of toxicity due to arsenic and also due to thallium. There were presence of hyperkeratotic and hyperpigmented patches with wasting of the leg muscles. There was also evidence of hyperpigmentation on the abdomen, and we can appreciate the presence of excoriating skin lesions which were present in the lower limbs. So this time a serum toxicology panel report was sent, and we got a number of other heavy metals also positive, but arsenic was significantly raised, being 2,190 micrograms per liter. The next we sent was a 24-hour urinary arsenic levels, which came out to be 138.81 micrograms per day, with the normal being less than 50. So according to the CDC criteria, the patient fit into the diagnosis of arsenic toxicity. And since he had an intake of more than 3 years, so a possibility of chronic arsenic toxicity was considered. He was treated symptomatically with gabapentin, antioxidants, and physiotherapy. We were planning to give BAL to the patient, but the patient developed reactions to it, and hence it was not continued, and we opted for D-penicillamine as a chelating agent. The patient showed slow improvement in symptoms at the time of discharge, and serial serum arsenic levels, which we followed since the patient also opted for repetition of it, we continued to follow this, and the patient had declining serum arsenic levels, and similarly they were declining 24-hour urinary arsenic levels also observed. So to discuss, arsenic is a common environment.
What you learned from this case?
Always we should take.
And initially we considered as a GBS, but he came and then he got just some estimate to get the treatment. Yeah, he was not able to afford the cost of IVIG initially. So he took the estimate to get the money from some Chief Minister Relief Funds. And then after 10 days, he again came. So, and he was considered as a case of GBS because the typical features were matching. So he was given IVIG. Again, he continued to worsen, and then he was given methylprednisolone. There are no improvement. After oral steroids, in between he developed UTI and fever. So in between the steroids were interrupted for a few days, but again it was continued, and still he was progressing. So, and we did all those investigations.
We should always.
Before we continue about the discussion, there are a few questions that Dr. We need to ask. One question is that what was the dose of penicillamine that was used for treating this arsenic intoxication, and is that required for all patients who develop arsenic poisoning induced symptoms?
Initially, this BAL was not available in UP, so he talked to the some contacts with the Samarth Pharma manager, and then he procured this BAL. And after the sensitivity testing was performed, but he was reacting to that, so it was stopped. After that, actually, he was gradually worsening. Even after these treatments, he was bedbound, he not able to do the routine activities. So that's why we opted to give the D-penicillin. Initially, we started with the low doses like 250 milligram twice daily, thrice daily. Then maximum dose we give to 500 milligram 4 times in a day. But even the higher doses can be given. But after that, there was the progression was slow, and he started improvement. So this dose was continued, and we continuously monitored the urine levels, and it was declining. And when it came to the, I think after 3 weeks of the therapy, the levels were significantly low, so that was stopped. And in between, we monitored the urine, blood parameters, everything was monitored.
Right, sir. So another question is that why is albuminocytological dissociation seen in patients with arsenic poisoning induced neuropathy?
Actually, the toxic,
Because we've had 2 cases discussed and both of them had CSF.
mildly
showing-
elevated protein, not much high, that we typically see in the JB syndrome.
So could just be a reactive
Yes,
increase in protein then rather than
to the true inflammation of root. But it this arsenic damage to the, there are several phenomena. It impair the damage to the axons.
Sir, could you
damage to the
place your
myelin.
mic a little closer here?
Yeah, damage to the axons, damage to the myelin has been reported. So few toxins, usually the toxic neuropathies are usually axonal sensory motor polyneuropathy, but in few cases like in diphtheria and hexane, in arsenic and procanamide, gold and other things, the demyelinating neuropathy have been reported.
Right.
But the mildly elevated CSF in other there may be some injury to the myelin, and then some inflammations, reactive inflammations can be there. So that may be the possibility.
So, one more question is that, is there any role of plasmapheresis while we are chelating the patient to help in symptom improvement and removal of the toxin?
We reviewed the literature at that time. Can we go for the plasmapheresis? But it didn't supported the therapy. So we opted for this more safer option like BAL and deep inflammation.
Thank you. Thank you, sir.
Even sir, I would like to know. Hello,
Sir.
Dr. Ayush, I would
Yes.
like to know your experience, because we are having only these 2 cases. Even literature says that only during acute phase, if we give deep penicillamine, then it is effective. In chronic cases, there is not much role of deep penicillamine. So what's your experience, or some other member who is much more experienced in treating these type of cases? I would like to know their experience.
Sir, we've had a few cases, and those patients we did not give chelation, and just by stopping that exposure, the patients improved. We had one case who developed a post-mercury poisoning peripheral nerve hyperexcitability, and once we stopped that Siddha medication that he was on, the patient started improving. We did not require chelation. Similarly, another patient who mimicked CIDP, just like this case was there. There also we did not require chelation. So I agree with what you're saying, sir, that chelation is usually reserved for acute presentations more than chronic ones.
So in literature, this is written. So during my first case, I opted for not to give for 2 or 3 weeks, but no improvement. Then I thought it's better to give, and let's see the response. After 3 months, patient started improving. During first 3 months, even with deep penicillamine, there was no improvement.
Right, sir.
So
Right.
this was my experience in this case.
Thank you. Thank you, sir.
Even in our case, the blood arsenic levels, even after the 2 to 3 weeks, it was quite high. It is written in the literature that usually the blood arsenic levels declines, and the only useful test is the urinary arsenic levels. And we asked further whether he takes any special water procured in the bottles that is supplied in the cities, but he takes RO water. And just we asked his wife, that she confirmed that he takes various medications and procures online. So then suspicion was there. Even we stopped all the multivitamins we were prescribing to the patients, and only giving the just symptomatic this PPIs and this neuropathic treatments. So from what source he was receiving, and the levels are so high still.
Sir.
Yes, Raghav.
Raghav, you can continue and finish in the next minute.
Okay. Thank you. So arsenic is a common environmental toxin which is found in water and air. It is used in the glass industry and semiconductors. Medically, currently arsenic dioxide is used to induce inflammation in patients with APN, and it is used in certain non-Western traditional medication products. So the most frequent neurological complication of arsenic intoxication.
Sorry, Dr. Raghav, for stopping you. I think since we're short of time, there are a few questions that have come in. We'd rather take that for discussion.
Right.
Dr. Ganesh is asking, should we continue immune modulation during chelation? Like your patient developed
Yes, sir.
CIDP post arsenic exposure and poisoning. So would you want to give the patient an immunomodulator along with chelation, or will chelation suffice for improvement?
So there is no evidence of use of any immunomodulated drugs in the treatment of toxic neuropathies, and I think chelation suffices, and also to stop the exposure of the patient.
Right. Another question by Dr. Rajesh is that at what stage of arsenic toxicity do cutaneous markers usually appear?
Usually, the cutaneous markers, they appear after 2 to 3 weeks of continued exposure.
So is there a cutoff with which we can say that if cutaneous markers are there, the level is likely to be above a certain amount?
So there are certain cutaneous markers such as present of hyperpigmented and
I'm not asking about the markers. I'm asking, like, if markers are present, can you say that probably the levels would be above, say, 100, 200 or something of that sort?
presence of Mies lines would usually suggest that the levels are at a higher level.
Okay, right. Thank you. Thank you for the excellent presentation and discussion. And with that, I think we've come to the end of our allotted time. Do join us for the next webinar that will be on the second Sunday in August. And I'd also like to request everybody to please send in your cases to the email address that has been mentioned prior. That is ianynf45@gmail.com. And looking forward to an excellent academic discussion again the next month. Thank you so much. Have a nice weekend.